My thanks to them for having me here for this a very pertinent topic of the panel discussion, which this is the dilemma we confront each and every day if we are dealing onco patients in our ICUs, that what to do and what not to do. So this is a big dilemma. And then there are a lot of other dimensions which are involved in this. There are financial angles, because we all know that the oncology services and treatments, they punch a big hole in patient's pocket. There is a lot of lot of costs involved in managing cancer patients for a long duration of time. Then you have other dimensions also, a lot of ethical dilemmas. So to discuss some important topics related to all these, and specifically to the organ support in cancer care, we have we will have this panel discussion so that we come out with some good points, some takeaway points, some conclusions to apply to our ICUs and patients. For that, I would like to invite my fellow panelists for this panel discussion. Dr. Srikanth Srinivasan. He is consultant and head critical care medicine, Manipal Hospitals, New Delhi. His areas of interest, we all know point of care ultrasound, POCUS. He's a champion. Then ECMO and advanced mechanical ventilation. He's associate editor IJCCM, author of ISCCM Manual of Critical Care Ultrasound. Then we have Dr. Amrita Ramaswamy. She is clinical hematologist and principal consultant, Department of Hemato-Oncology and BMT, Max Super Speciality Hospital, Shalimar Bagh. Her areas of interest are acute leukemia, multiple myeloma, and consultative hematology. Then we have another dignitary with us today, Professor Dr. Ravinder Kaur. She is Director, Professor and Head, Department of Critical Care Medicine, RML Hospital, Delhi. Her areas of interest are critical care, RRT, POCUS, and BSDC. So, thank you all for being here. So as I told you, this is a big dilemma, a lot of things which we'll try to discuss. We'll try to come out to a conclusion. We all know that the number of cancer patients admitted to intensive care unit is rising because we have good facilities as far as care is concerned. We had very good equipments. We have very good treatment facilities in tier 2, tier 3 hospitals in cities also. So that is why the life expectancy and the prognosis of some of the cancers have really improved. Many patients who are admitted in the ICUs for surgical reasons like post-op, as a post-op case after onco surgery, they have very good outcome for obvious reasons. That is not the case with the medical oncology patients. After said all that, despite all the recent good improvements and advancements we have in cancer care, the occurrence of life-threatening events such as the neutropenic sepsis, acute respiratory failure, ARDS, need for urgent surgeries, and so on and so forth are still very common and pose a big challenge to all of us. Now I'll open up the question. The first question will be for Dr. Srinivasan. So what are the common indications, Dr. Srinivasan, you see as far as cancer patients are concerned for admission in ICU, specifically in context to hematology vis-a-vis solid organ tumors?
Yeah.
Hello. Yeah.
Can you hear me?
Yeah.
That's good. Yeah. So the common indications with hematologic vis-a-vis solid organ tumors. Let's talk about hematological first. So that will depend upon the timeline of the disease, right? Quite often or not, it may be the presenting symptom the disease, when the patient may present with some kind of pulmonary or renal or some kind of dysfunction. And you diagnose the hematological malignancy at that stage with the metabolic abnormalities which accompany it. The most common indication still being infections, febrile neutropenia, infections in the respiratory system and elsewhere. Then during treatment, we may have tumor lysis syndrome, right? We may have organ dysfunctions, we may have pulmonary, we may have renal, we may have liver dysfunctions, neurological dysfunctions, bleeding manifestations, DIC, thromboembolic events, and so on. And if the patient is post-transplant, then another set of problems, maybe infective problems, graft versus host disease, veno-occlusive disease. So there's a whole range and spectrum based upon the timeline of infections. Solid tumors, well, there again, it will depend upon whether the manifestations of disease per se, in the form of infiltration of the specific organ in which it has started from or metastasized to, could be post-surgical or could be otherwise a medical manifestation. Post-chemotherapy, they may end up with neutropenia and sepsis. Infective things are already existing there. Or could be an effect of the medication which they are receiving, the form of chemotherapy and its side effects. So these are the predominant indications. But yes, on the whole, it is the infective issues which are the major cause for admission to the ICU, and they are number one throughout the world.
Yeah, that's true. Just to summarize what Dr. Srinivasan just elaborated. So there can be, yes, of course, cancer-related issues, disease-related, or treatment-related issues, and there may be issues which are not related to both, and the patients are having coincidental issues with the comorbidities. So those can be the reasons. So the most common reasons which we just discussed in ICU for any patient will be any organ failure because of sepsis, because of respiratory issues, because of renal failure, as the kidney is one of the very frequent bystander hit by the other causes. Then you have septic shock, so on and so forth. So we have cancer-related patient in ICU with multi-organ failure. So this is for Dr. Ramaswamy, are multi-organ failure rates or mortality rates higher in cancer patients? And what are the common organs to take the hit when they are hit?
So I am a hematologist, so I will speak only with the perspective of a hematologist. Yes, obviously the multi-organ failure rates and the mortality rates are higher in cancer patients because these are patients who are on chemotherapy, who are on immunotherapy. They tend to be immunocompromised. Their immune systems are not the same as a regular 35-year-old or a 36-year-old or a 60-year-old for that matter. So all of us know that the reasons why hematology patients get admitted in the ICU, most of the times it's febrile neutropenic sepsis and septic shock. So infections are obviously higher in cancer patients. They are more severe in cancer patients because of the simple fact that these patients are on therapies which compromise their immune systems. And the common organs to take the hit, obviously it's the kidney, acute kidney injury, sepsis induced septic shock, gram negative sepsis is probably, I think, the commonest organ to take the first hit. And once the kidney is hit, then gradually, multi-organ failure sets in. I think the commonest organ is kidney. Other organs we do see. Sometimes we see reactivation of hepatitis B in patients who receive immunotherapies. A well patient on immunotherapy, suddenly recently had a patient who had reactivation of hepatitis B. He was a myeloma patient on daratumumab. It's a rare complication, but he had reactivation of hepatitis B. And I've seen a primary CNS lymphoma patient on rituximab had reactivation of hepatitis B, had fulminant acute hepatic failure. So yes, organ failure can happen because of the therapies that we give, and obviously the mortality rates and the multi-organ failure rates tend to be higher in cancer patients.
Can I ask you one more question, Dr.
Yes.
Ramaswamy,
Yes.
from the hematologist's perspective? So why is that?
We should have a medical oncologist also on the panel. Yeah.
Yeah, that can be requested to them. So why is that so that the incidence of neutropenic fever is very, very high in in hemato-oncology patients, in acute leukemias, lymphomas, maybe to the tune of 90%, as compared to the solid organs, where we have hardly 5%, patients who suffer with the febrile neutropenia.
For the simple reason that the seat of the malignancy is the bone marrow.
Yeah.
The site of the malignancy in hematological malignancies, or for that matter acute leukemia, is the bone marrow itself. So obviously when you give chemotherapy, the normal bone marrow cells take a hit along with the cancer cells, and that's why the rates of neutropenia tend to be higher in hematological malignancies, patients with hematological malignancies treated with chemotherapy, because you are targeting the bone marrow itself is the site of malignancy. That's why the neutropenia rates are higher in hematological malignancies.
So army takes the role of terrorists here, something like that.
It's like a coup,
Yeah.
I would say. Yeah, like in Bangladesh, probably what's happening in Bangladesh, I would say.
That's right. So yes, if we talk of the multi-organ failure rates, they are not much different if we compare oncology versus non-oncology. But when in oncology patients the organs take a hit, it is a big hit, and the toll is also high. So adult oncology patients who require mechanical ventilation, ARF, the mortality is very high. If we talk of ARDS in oncology patients, again very very fatal. If we talk of ARDS in hemato-oncology patients, nearly 100% fatal. So that is the truth. Now MODS mortality is in adults is typically more than 60% when two or more organs fail, and when more fails, the mortality reaches to nearly 100%. Now, this I have taken from Swiss Medical Weekly, a review article on oncological patients in intensive care unit, prognosis, decision making, therapies, and end of life. And they have, divided the prognostic factors into some positive and negative. Like age is a negative, more the number of organs involved or failure, more is the mortality, respiratory system, and so on and so forth. Again, for risk stratification, we need to have some kind of scoring systems which we must follow in our ICUs. uh, you can choose your own, but we have a lot of studies on these. Higher Apache 2, 3 and SEPS 2 scores on admission correlate with mortality in some studies. Others suggest that they are less reliable in patients with cancer or hematopoietic cell transplant recipients. A small number of studies of patients with solid and hematologic malignancies reported that increased risk of death was associated with a higher SOFA score. So, risk stratification at the admission and on the run when the patients are being managed in the ICU is very, very important. So, we have a patient in the ICU with some kind of organ failure. Patient requires mechanical ventilation. This is a very common scenario which we have in the ICU. Now, what kind of mode you should choose? NIV versus mechanical ventilation, or HFNC versus NIV? What is your take, Dr. Kaur, in this?
At the outset, I would like to thank the organizers, Dr. Praveen Kaur and Dr. Saurav Das, and thank you for the question. So when we are talking about the mechanical ventilation in cancer patients, we should know that the commonest and the most unplanned reason for ICU admission for these patients is acute hypoxemic respiratory failure. And we see that once these patients they come on mechanical ventilation, the mortality is very, very high. And we see that the causes of ARF in these patients, if we see that in solid organ tumors, the incidence of ARF is around 5 to 10%, which goes up to around 50% with the hematological malignancies. And if we go with hematopoietic stem cell transplant, it goes up to 40 to 80%. This is as per the literature. And the commonest cause of these acute respiratory failure is not only infections. As we know that these patients are immunocompromised and they have infections, but most importantly, it is a non-infectious causes, like we have the interstitial lung diseases, diffuse alveolar hemorrhage. So these conditions, the non-infectious causes are most difficult to diagnose, they are most difficult to treat. So coming on to the ventilatory modes, we see that one of the commonest reason for putting these patients on mechanical ventilation is that they end up in ARDS. So as a result, we see that invasive mechanical ventilation is a very common mode of therapy which is used. But since these patients are immunocompromised, so the invasive ventilation, particularly intubation, it has an increased chances of infection. So if we go by the latest guidelines of the ATS and the ERS, that is the European and the American Thoracic Society guidelines of 2017, they have advocated the role of non-invasive ventilation in these patients, because here NIV has an advantage of decreasing the work of breathing, improving oxygenation, ventilation, and definitely we are avoiding the deleterious effect of putting a tube inside the patient. But when we talk about NIV, we have to keep certain things in mind, and that is we need to have a lung protective ventilation protocol in these patients. So the pressure support needs to be kept low so that the patient is able to generate a tidal volume of around 6 ml per kg predicted body weight. The PEEP needs to be higher so that we avoid the alveolar de-recruitment. And again, the FiO2s have to be adjusted so as to get the saturation as we aim around 88 to 92%, or some centers also recommend more than 92%. So I would just like to add here that even HFNC, that is high frequency nasal oxygen therapy, has again come up as a very useful therapy in these patients, because here also we are avoiding intubation. And recently there has been a trial which was published in Lancet in 2022. So this trial is a Florali IM trial. So this trial has compared the use of HFNC with the other group was getting HFNC and NIV. So that was alternating. So this trial was carried out in 29 ICUs of France and Italy. And the final results of the trial are just out. And though they say that there is not much difference in the 28-day mortality, because that was the primary outcome that was used. But one main problem was that it was underpowered. The study was underpowered. The number of patients they had taken was close to 400 or so. So we can say that HFNC is another therapy that we can use in these patients, because as such, the invasive mechanical ventilation has a very high mortality. As you mentioned in your previous slides, it is close to 50 to 70% in these patients. Thank you.
Yeah, that's true. Thank you. So yes, HFOV is out of question. NIV has, as we all know, grade 1 evidence for usage in immunocompromised host or patients with type 1 respiratory failure. So that should be always kept in mind. Now, the question of using NIV in palliative care also arises quite a few times if you are dealing oncology patients. So there again, it is a dilemma whether to go for it or just put patients on normal oxygen support. So using non-invasive ventilation for palliation of terminal dyspnea should be individualized. It has to be discussed with the patient party. Then you reach to a diagnosis, what kind of exit the family and the treating team wants for the patient, of course with their consent and the designated caregivers. So this is from
Pratush, I
critical
would
care.
just like to add one
Yeah,
thing
please.
here. One has to differentiate between hematological and solid organ tumors in this case. See, just labeling every cancer patient as in one's common basket would be wrong. The grade 1 evidence is predominantly for those with hematological malignancies, where use of invasive ventilation by itself has historically shown to have poor outcomes, but that also started to change to some extent. In fact, those who have survived mechanical ventilation go ahead and have a reasonable 1-year survival as is expected with some patient who did not have the critical illness. In solid organ tumors, especially those who are on intent to treat, those who are actually on treatment therapy. So if they have worsened because of some infective cause, maybe distant or whatever, in those cases, one should not be too reluctant in going in for mechanical ventilation. So giving a blanket statement that NIV is the way forward for all cancer patients may be probably too much of a stretch to actually fit them into, right? Especially with the changing outcomes and improved survival of these subset of patients.
That we'll discuss. Yeah. This is for immunocompromised, the statement was, if possible. And then again, this is about the trial, a fair trial of NIV always. And then you look whether your patient's status, dictates you towards invasive ventilation or not. So a lot of factors have to be kept in mind. So this is from critical care medicine, from Azulu et al. Improved survival in cancer patients requiring mechanical ventilatory support, the impact of non-invasive mechanical ventilatory support. So this is about the judicious use of NIV Yeah. So, they concluded that mortality has improved over the past decade in critically ill cancer patients, even those who require mechanical ventilation, and suggest that this may be in part because of a protective effect of non-invasive. Now, this is for Dr. Srinivasan. We, all treat sepsis. We all know what is the basic difference if we talk of sepsis in cancer patients as compared to non-cancer patients. So, what is your take on this?
Yes,
How to
see,
deal with sepsis in this subset?
uh, Dr. Amita already mentioned about this. So obviously the incidence of and the survival and the cancer patients are very high risk for developing sepsis. First and foremost, the incidence is almost tenfold higher for that matter. Now, coming to those who develop neutropenia versus not neutropenic sepsis, it doesn't require a lot of intelligence to understand that neutropenic sepsis obviously is a totally different ball game, where the survival and the progress is poor, and the progression to multi-organ failure is also extremely high. And the risk to life exists as long as the neutropenic phase continues. The longer it continues, the more is the chances that the survival outcomes may be poor. As compared to this, the non-neutropenic sepsis still have a high mortality, especially when we talk about the hematological as a subgroup, but still a much better outcome as compared to those patients with neutropenic sepsis. So, in sepsis in cancer patients, not only purely because of neutropenia or because of chemotherapy, it is by the cancer per se itself. Even solid organ tumors have been found have at the level of the molecular signaling. There is problem with the way the immune response occurs in these kind of patients. So they are anyhow prone to sepsis. So cancer patients, the very presence of the cancer itself will reduce your immunity. Your medications further reduce your immunity. And if you develop neutropenia on top of it, then the possibility of mortality and going into multi-organ failure becomes much more high.
Yes, as Dr. Srinivasan just elaborated, we have a lot of different perspective in patients of cancer who present to us in sepsis. A lot of other paradigms which we need to keep into mind when we deal these patients. So, usually also in a common ICU practice, we require renal replacement therapy for kidney dysfunction, acute kidney injury. Uh, Apart from the routine indications of RRT in a non-cancer patients, what are the other unique or specific indications of renal replacement therapy in cancer patients, Dr. Kaur?
Okay. So we know the routine indications. First of all, I would say that these patients suffering with cancer, they are prone to both AKI as well as CKD. CKD causes, or we say the risk factors for CKD is the same as we have for the general population. Now coming to AKI, so AKI is again very common in these patients because as you have earlier discussed that the kidney takes a major hit. So one of the major reasons for AKI is the malignancy itself, So for example, there are certain malignancies which infiltrate the renal interstitium, like we have the renal carcinomas, lymphomas, leukemias, or even for multiple myelomas because they infiltrate into the kidney. So these are the reasons which cause the AKI. The other reasons specific, and these are the patients who would be requiring renal replacement therapy, whether it is an IHD, it is a CRRT, it is a SLED, or it is a renal transplant. Then the other indications could be patients who are receiving chemotherapy because chemotherapeutic drugs, most of them have an nephrotoxic potential and though they act by different pathophysiological mechanisms, but the end result is AKI. The commonest would be like methotrexate is there, then we have mitomycin and cisplatin. So these are very common drugs which are there. Then the patients of the malignancy patients, in fact, they have a lot of hemodynamic compromise. So hemodynamic compromise again leads to AKIs. So one reason is septic induced AKI. Now these patients, they're already immunocompromised. They're already fragile, frail patients who have poor oral intake. They have nausea, vomiting. So as such, their general nutritional intake is very poor. So once they come to the ICU, they're very prone to infections. So sepsis-induced hypoperfusion and septic AKI is one of the hemodynamic reasons why these patients, they end up into AKI. The other important cause of AKI would be the heart failure. So besides the usual causes of heart failure, which we already know, like essential hypertension, etc. So these patients, They are also sometimes taking cardiotoxic drugs, like we have the anthracycline derivatives like doxorubicin, danorubicin. So they cause damage to the heart, and the heart failure itself leads to hemodynamic compromise. And there are few more reasons I would just like to add. One of them is when the patient comes to ICU, our antimicrobials have got nephrotoxic potential. We know there is a whole list of drugs. Contrast-induced nephropathy is very common because these patients are taken, but these are not specific indications. Coming to certain slightly more specific indications would be tumor lysis syndrome. So that is, again, we know TLS is seen in patients where there's in high-grade malignancies because of the rapid degradation of tumor cells. So here the main organ which takes the hit is the kidneys, and it is because of the release of the nucleic acids which finally get converted to the uric acid, and finally it gets deposited. So there are other many reasons like hematopoietic stem cell transplant, as was discussed in the previous lecture. There also the kidney takes a major hit. So these are certain specific reasons why these patients, they will require a renal replacement therapy in the ICU. Thank you.
True. As you told, the direct effect of malignancy or HSCT, chemotherapy induced injuries, drug associated nephrotoxicities, obstructive nephropathies because of the retroperitoneal and urothelial cancers, nephrectomies because of the cancer, volume depletion, tumor lysis syndrome. All these may be taken as some, from different perspective in these patients. So when we talk of the organ supports, this always comes up in the discussion, ECMO. So I know you.
I have never used
Yeah.
ECMO in my life, but I'll try to answer this question
Please go
as
ahead.
honestly as
And
possible.
then we'll take the views of
the intensivists.
Yeah. Sure.
Okay. So I just did a little bit of reading about this. So ECMO is not universally applicable to all cancer patients. All of us know that if there is a reversible cause which has caused acute respiratory failure in a cancer patient whose primary malignancy is under control, is under treatment, then probably ECMO is justified. As an example, I would say, let's say we have a post-transplant, post-hematopoietic stem cell transplant patient has developed a pneumocystis pneumonia and has developed acute respiratory failure. So, and if they have the finances and if they have everything, I think, and if it's a young patient, obviously we can go all the way. We can consider ECMO in that particular patient. So in cancer patients, I think patients who have, like, let's say mediastinal masses, in which you are planning a tracheobronchial surgery. So under ECMO support, these patients have successfully undergone surgery and they have been taken off ECMO and discharged in hospital. There are plenty of case reports. When you talk about hematology, I was quite surprised to see that somebody with a primary cardiac lymphoma, there was a case report of a patient, primary cardiac lymphoma, obviously heart failure. Obviously, lymphomas, we know they are extremely sensitive to chemotherapy. So chemotherapy plus ECMO, that patient did well, and according to the case report, she got discharged. So without definitive therapy for the underlying malignancy, I am not sure what's the role of ECMO. There was another case in somebody who had a primary mediastinal B cell lymphoma, had tracheal invasion. So this patient was again put on ECMO, received chemotherapy for the primary mediastinal B cell lymphoma, and then obviously the tumor went away and he improved. He was taken off ECMO and discharged. So these are the rare case report success stories that have been reported in literature. But I think we should always, in any patient, just like any other clinical decision in medicine, we need to look at the risk and the benefit ratio to decide whether we need to utilize this modality of treatment or not. As simple as that.
I think it can't be better than this, Dr. Srinivas. Want to add?
I don't think I can add any more. She has just totally summarized. But yes, can it be a universal yes or no? No. It has to be on an individual case-to-case basis, and there can't be any recommendations or guideline which says an absolute no or an absolute yes, and which patients to use, which patients to not. The discussion obviously will have to involve the primary, the medical oncologist or the hematologist with regards to what is the phase of the disease the patient is in and what is the prognosis of the patient per se. So that will make a big point in the decision making, especially those who are on palliative care. There, the ECMO doesn't really make a lot of
Has
sense.
to be individualized.
Yes, it has to be individualized, right?
That's true.
And the rest of the indications she has already summarized very well. Yeah.
Now, a very important angle, the money, finances. So a lot of economic implications, financial issues, which we all face, especially in corporate sector, when we offer high-end treatments, because the cancer takes quite a long time to settle, and maybe after settling once, it will come up again and again and again. So what are the economic implications, Dr. Kaur, of providing organ support? What do you think? What do you have in your mind when you tackle these patients in ICU?
When you talk about cancer patients, so we need to know that cancer, as well as its therapy, it tends to cause damage to the organs. So oncomedicine has a very important role of supporting the failing organs. So when we come to the organs, in fact, as you have enumerated, whether it is the kidney requiring RRT or IHD, whether it is the heart, the serious arrhythmias, use of ECMO, as it was mentioned, respiratory, invasive or non-invasive ventilation, or any form of oxygen therapy, or it could be a liver. Patient may require MARS, liver transplant. The patient requires the requirement of transfusion medicine support is required, because these patients, they have pancytopenia, so that support is also required. Then we have a psychological support. So we see that a number of organs need to be supported in cancer patients because of the disease itself, because of the side effects of the therapies. So when we come to the economic implications, we have to see the risk-benefit analysis, whether the patient has any positive functional outcome in the long term or not, as it was previously discussed. Because all these organ support therapies, they are extremely expensive. And in government setups, though it is borne by the hospital to some extent, but when we come to private setups, it is out-of-pocket expenditure. So again, it is very expensive. So coming to, when we talk about the risk-benefit analysis, we know that the benefit definitely is in the form of we improve the organ function. So definitely the patient is going to have less amount of complications, and there'll be less amount of ICU admissions. The patient will have a better functional outcome if it is possible. But when we talk about the risks, there are a number of risks. Whatever therapy we are doing, whatever organ support we are trying to do, it may have its own complications. For example, if you're trying to put a line, that it may have complications like hematomas. It may cause increased risk of infections. Chemotherapy has its own side effects. Moreover, it causes a lot of emotional and psychological distress in the patients, because they are separated from the families. And these kind of supports, they can happen in the hospital. We can do it in the ICU. Or sometimes the patient even go for daycare centers or even the home care, depending on that. But when we talk about resource-limited countries like ours, then there is a lot of, then in fact, we have to think about the decreased amount of infrastructure. And at the same time, there is decreased manpower, there's decreased amount of essential medicines. And again, the finances come either on the government or it comes on the patient itself. So all these things have to be kept in mind. If the patient has a good outcome, then definitely we should go ahead with it. And otherwise, in fact, it has to be weighed.
Okay, yeah. So, if we talk of the cancer care specifically, as I'm also into an institution where 30-40% of my patients are from oncology, what and the RGCI itself, people, Dr. Kaur or someone else can pitch in. So there are some support groups and systems which are there at my place, some NGOs which offer help. Some kind of institutional support is also there in terms of bearing the expenses through EMIs. This is also one option which is given. And then some PM care fund, and through MLAs and MPs they apply for the care. So I think these things also need to be highlighted in the larger interest of the society, that there are other options. Do you want to add to this, Dr. Ramaswamy? Because your patients would be the patients where maximum amount of money is
The
drained.
formula is very simple. I look at the long term prognosis of the patient. Like, let's say I have a a patient who is in remission, received chemotherapy, went into neutropenic sepsis, acute kidney injury. I am expecting the neutrophil count to recover in the next 3 to 4 days. I would go all out for that patient. Compared to a patient who has refractory disease, count is never going to improve whatever I do. Same sepsis, same acute kidney injury, I would probably counsel against renal replacement therapy. So it all depends to me on the basic condition of the underlying malignancy, whether that is under control, whether that is probably the main thing in my mind whenever I take a clinical decision.
But there is no institutional financial hand holding of any kind. Do
So
have it
we
in
have
RGCA?
mostly in my hospital panel patients. So if
Yeah.
I put a patient on ventilator, it is basically taxpayers' money,
Yeah, I know.
your money and my money. So I think we need to uh, utilize resources logically, and I think it's important to. These are difficult decisions.
Yeah, I know.
But then I think we need to think logically, and we need to make the right. We need to make the family, the patient families, take the right decisions.
Yeah, that's the point. Yeah. So now, this question which has some philosophical angle to it, a touch of end of life care, a lot of dilemma which is there. Two sides of the coin: death in the ICU, which may prevent prolonged suffering for the patient and the family, and the other is the successful ICU treatment with a query, which gives the patient expected lifespan with again the same churning in the ICUs and hospitals. What would you do?
It's not a question of my preference here, right? I'm not here to determine whether a person is going to survive or die. My job is only specific is that in discussion with the primary team, which may be the hematologist or the medical oncologist, to sit down with the patient attendant and explain the possibility of survival, the possibility of disability, the cost implications which are involved, and what are the further issues that could likely crop up in the future if I go in for X or Y therapy. As Madam has rightly pointed out, the entire discussion will be based on what is the impression or what is the possibility of outcome of this patient in a long-term basis. And a long-term basis is a very relative thing. Some people talk about 6 months, some talk about 1 year, and some talk about more than that also. And the expectation of the attendance may be totally not in sync with the expectation of the treating doctors. See, the attendance for them, even a few days may be very, very valuable for them. And some of them are very pragmatic in saying that we don't want them to suffer so much. So the idea is for the clinical team is to, first of all, get an impression of what is the likelihood or the trajectory of the disease per se, and what is the likelihood of the outcome, first and foremost, from the medical perspective. Then speak to the attendants, putting all the facts on the table. And we feel that even if I have successful treatment, the patient is going to be ending up with some disability, stroke, persistently on dialysis, long-term bed requirement of high care medical facilities. You have to create a ICU at the home and take care of the patient, a lot of expenses involved. Then one has to realistically prognosticate those people with regards to this. There cannot be a clear-cut saying that there is no point in doing anything in the future, because there's a lot of emotional aspect to this also, which one cannot totally rule out. As a medical professional, we should not sort of replace or downgrade that emotional aspect as well, but one has to put those things in a true perspective, and all the facts have to be placed on the table without actually honeycoating them by saying that some things may get better over a period of time. One has to be very realistic in this thought process, is that this is not going to improve and this is how the person is going to stay. If we are willing for this, then well and good. If not, then one should not probably prolong it. If the patient is able to understand and comprehend their condition, then they should also be a part of this discussion. I mean, ideally they should be, because the true decision maker should be, or the autonomy of decision should not be snatched away from the patient at any stage of time. Right? So this is a philosophical answer to a philosophical question. There cannot be a clear answer to this. If you ask me my personal preferences, in case somebody is going to end up with a lot of disability and suffering, I probably will say don't do anything.
The idea of putting this question was to have or project a roadmap which we clinicians should also have.
I would like to add here.
Yeah,
So it is not about what we feel.
Exactly.
So what happens all the time, because we have an onco center, we are just them. Whatever you may tell them, whatever you may prognosticate them, nowadays we are seeing people will opt for everything possible. These are the lines: do everything possible despite. think Dr. Ulas, the first call whenever comes to us, the first call I give to oncologist and medical oncologist, what is the disease status? And they will guide you. They will tell you that please discourage them. But whatever you may say, so I think last month, the only request was to let him live for one. So you see, so this is this
So,
kind of request. What
So,
That's true.
and,
These are
and
the
then
common
quite often
happenings.
that is proportionate to the who's paying for the patient.
Exactly.
If the taxpayer is paying, then please go on for whatever time you wish to do and do whatever you want to do.
we don't have any panel or something with us. Most of them are cash paying patients. Still, they opt for. But still, sometimes you don't have a choice.
Yes. So the ultimate decision will lie upon a combined discussion
Yeah.
but through all the stakeholders which are involved.
Yeah.
So that's
But
why there
one
can't be a clear-cut
request
answer
which
to
keeps
this.
on coming is let them go peacefully. Let them. This has now. This is the change. Earlier, people were not aware of this thing. What now? Everybody will.
But that again will when both the treating team are totally convinced that this is what is in the best benefit of the patient.
Definitely.
If there's any, because everybody wants to cling on to some hope. If somebody gives some kind of hope or just some words which are inappropriately placed,
Yeah.
then they will cling on
If
to
you
that.
add there
Of
is a
confusion.
5% hope, and then it changes everything.
I would just like to add that finances play a very important role, because many a time we get patients coming from private setup to government setup saying that because ICU stay is a very expensive thing in private. So here everything is free. So I think finances is very important, and that is one of the major deciding factor for letting the patient, even though it is an end of life care, then also they would say that, okay, let the patient come here. So I think that makes one of the very important aspect. Thank you.
Yeah, that's true. Finances plays the most important role. So this is the last one. There is a little crossover also. We have talked about this also. When should we start talking about the palliative care to the patient and the family?
Sir, sorry, I'll interrupted this question. We have a full panel discussion on this particular question, so I think you can omit this question.
Okay, yeah.
We have a full
I
panel coming
already
up for this
omitted two,
question.
three of my questions after they interrupted. So yeah. Okay, so we'll do that. So the idea of
There's
putting
another
it
question below.
here, yeah, there you can go. So we focus more on
So I
quality
think
of life.
quality of life is something that is really ignored. We never take into consideration what the patient actually wants. Nowadays, the focus is more on patient-reported outcomes. There are questionnaires in which objectively assess the quality of life of the patient, and obviously prolonging life is important. But then there's a very nice saying. If you look outside research in referral hospital, it says the aim is to not add years to life, but life to years. So quality of life is something which we hardly discuss with the patient. We keep giving chemotherapy, immunotherapy. Patient has loss of taste, doesn't feel like eating. So I think quality of life is something that is not discussed, and we should have a separate panel discussion on that totally.
Yeah,
So
we'll
just
have
like to
that.
end with this. Thank you.
Yeah. So I think the idea of putting this was that this has to go hand in hand. All the talks with the family and the patient should have continuous talks with the family. So we had a very good panel discussion. We discussed about the indications, what are the organ supports we have, what can we offer, different dilemmas, financial dilemmas, ethical dilemmas. So whatever we do, we have to keep in mind one important thing, which is the four principles of ethical medical practice. The patient's autonomy has to be kept at the top. Most of the times they are not in that state that they can give their consent, so the autonomy is transferred to next of kin. That has to be taken care of. Talking to the family and the patients if possible is the key. I like a punchline from one lecture, which is documentation of communication and communication of documentation is what will save us from a lot of legalities. Other principles like beneficence, that please do whatever you can do in the interest of the patient. Non-maleficence, that please do not harm, and the justice. And saving ourselves is very, very important. So the bottom line is that yes, organ support in cancer patients is feasible in many, but still futile in others. So again, the individualized care to the patient is the key. Thank you very much. Thanks a lot.